I'm going to go ahead and get started while people are coming because our agenda here is chock full. So welcome everybody. My name is Sadhana Devaraja. I am Managing Director and a partner at Health Begins. Really thank you all for joining us at Health Begins on this webinar called Complying in Advance. So we're trying to understand risks and opportunities for health equity in a time of uncertainty here. Before we start, we want to let folks know that this webinar will be recorded, and we'll be sending out this recording and deck to all registrants after the webinar. All participant lines will be on mute, and participants are not able to see each other on this webinar. If you go to the next slide, we really ask folks to use the Q&A function if you want to be able to ask any questions during this. That's the best way to get questions to the hosts and to the panelists. The chat will remain open. So if you want to just provide commentary or general questions on the webinar, feel free to use the chat function. If you feel comfortable, you can introduce yourself with your name, organization, and location in the chat as well. And finally, in the chat, my colleague Bassem will be putting in links here through presenters in the chat as well. And so you can click on those links that he puts in there. I think the kind of final piece here is, please join the conversation on Blue Sky. That's where we're doing a lot of our social media posting. And we have some handles as well for some of our presenters. And so please feel free to join us there. This presentation is scheduled to go for an hour. And as always, we really invite you to, share respect, curiosity, and joy in today's session. We have the best community here, and I'm really looking forward to being in community with you. And I love already the places that are showing up here. It really made me emotional this morning looking at the list and seeing how kind of far-flung everyone is. If you go to the next slide, about us at Health Begins, we're a national mission-driven strategy and implementation firm. We've long been serving Medicaid serving plans, systems, and social sector organizations, really exceed requirements and compliance kind of regulations. And so in some moments, those requirements can be footholds to catapult health equity efforts, and other moments it could be used as a bludgeon. We're ready either way, and we're so glad to be in this long-term impact space with all of you. If you go to the next slide, if you're joining this webinar, you're probably looking to understand the present policy changes a little bit more, assess the risks for your institution based on those policy changes, and then think of some actions together. And so if that's why you're here, you're in the right place. If you go to the next slide, I will say that while some of us have JDs behind our names, none of this is legal advice. And so I would say, if anything, my only advice is don't take legal advice from a webinar. We hope to inspire ideas and questions that you can return to your legal teams to your risk management teams with. But really, we're not here to provide legal advice. If you go to the next slide, I just want to take a moment to take a breath and recognize that for many of you, the risks that we're talking about here is not a future state that you're preparing for. These risks are already at your door. We know that programs have been paused, that folks have received stop work orders, funding's been frozen. And we also know that some organizations are kind of choosing to take a defensive posture and maybe pausing programs or cutting programs in advance of being ordered to do so. And so we just want to reflect on kind of that spectrum of where folks are, and that this can be kind of a painful time. But what we also know is that health equity work has never been easy. And for folks on our team, for those of you joining our webinars, for our clients, our partners, everyone in our community that's been involved in health equity work knows that it involves pivots and persuasion and persistence. It's always called for innovation. It's always called for reimagining the ways that we work to advance health equity. And this moment is a bit of a forcing function to leverage some of those skills and muscles that we've been flexing at maybe a more critical point than ever in recent history. And just personally, as someone who is a political refugee, from a country, and I sought political asylum with my family because of a government that left us behind. I think the most painful parts are when the institutions also fall away, because they need to be able to either stand up or be enablers in moments like this. And so really grateful for you all to be on this journey with us, to see how institutions can be supportive and not abandon equity efforts at this time. If you go to the next slide, these kind of mirror the objectives we have today, but it's also the path that we're trying to follow ourselves. As all of this influx comes through, we want to make sure we get the facts, really understand them, and not kind of fall privy to the kind of headline swirl that can happen, assess the actual risks that the order has, analyze it, and then convert that into action. And so after the presentations from our guest speakers, I'll talk a little bit about how Health Begins is trying to support folks to take this journey with us. But if we go to the next slide, without further ado, I want to be able to introduce our presenters. I will say that each of these presenters could easily spend an hour on the topic that they've been asked to present on themselves, and you would be enthralled the whole time. We asked them to keep it under 10 minutes, so it is going to leave everybody wanting, as well as my kind of introductions of them, which I'm going to keep pretty brief. So today we have Ken Thomas, who's a former legislative attorney for the U.S. Congress, the Congressional Research Service, and also the former editor-in-chief of the Constitution of the United States of America, Analysis and Interpretation. Megan Thomas, who's the managing principal of Medicaid Quality Initiatives at the Aurora Health Group. Both Ken and Megan are going to walk through some of that understanding piece of things, like help us level set, do some sense making about what's happening out there in the policy space. And then we're going to have Annie Chang, who's Vice President of Community Engagement from the Nonprofit Finance Fund, whose emails actually helped inspire this webinar for us, because they've been taking such a forthright stand on how to help organizations scenario plan, keep their backbone up related to equity efforts. And also Josh Hyatt, who's a consultant and professor on healthcare risk management, patient safety, and bioethics, will bring some frames to life for us that we can think about when applying kind of risk management principles to equity work. So without further ado, again, none of this is legal advice, and I will turn it over to Ken to get us started.
Thank you, Sadhna. This is, I've worked on Capitol Hill for many, many years, and these are some of the most complex issues that I've seen in my many years of evaluating the power of Congress, the power of the president, and the courts. And so I will try to give a brief overview, and we will take questions later. So next slide, please. Next slide. So what I'm going to talk about today is how we should be evaluating these presidential actions, both executive orders and memos. We're going to talk about briefly how the Constitution provides for separation of powers. And a lot of times the important thing to remember with the executive orders is that some of the powers that appear to be exercised in the executive order actually reside with Congress and probably will not be able to be exercised under the executive order. We'll talk about what an executive order is, which EOs are relevant to healthcare equity, and we will also talk about the litigation status of the various EOs. And again, I'll be covering a lot quickly. And finally, we'll talk about what legal resources are going to be available to allow health organizations to examine what is going on and to make their own evaluations as to how to move forward. Next slide, please. So the first thing to remember is, of course, the United States Constitution separates powers into the Congress, the executive branch, and the courts. All three of these entities are currently in play with many of these issues. The Congress, of course, has the authority to establish agencies, to give those agencies powers, and to provide limitations on the agencies, how they exercise those powers. The president, interestingly enough, doesn't have that many powers specified in the Constitution or in statute, For instance, commander-in-chief is a direct presidential power, but most powers actually reside with the agencies. And the authority the president has is to appoint entities or to appoint officials to run those agencies and then give those agencies directions. But the real power is in the agencies. Next slide, please. So let's just briefly talk about some of the congressional limits on the agencies. And again, all of these limitations are coming into play with the executive order. The power to regulate, that is controlled by the Administrative Procedures Act. That's congressionally passed statute that provides how agencies will be going along in their execution of regulations and authorities. An example of how the APA may have been violated, which I'll talk about, is the OMB memo freezing funds. Power to enforce, this is the power to exercise broad prosecutorial discretion to decide who is going to be subject to litigation. An example of this is the DEI executive order, which suggests that some private corporations are going to be pursued for DEI, for using DEI. And this is the kind of discretion that's generally very broad, but does run into limits. In this case, probably some free speech violation limits. Congress also appropriates money and directs how agencies spend, and the agencies are required to spend this under the Impoundment Control Act. So the executive order that deals with gender affirming care, for instance, provides certain conditions on receiving federal funds that are not specified by Congress in the act. And so in theory, this may violate the Impoundment Control Act. And finally, if an agency wants to fire federal employees, something that we're all very familiar with is going on right now, this has to follow the Civil Service Reform Act. And it appears that many of the firings that are going on do not comply with this. And so there may be real problems with that. Briefly, an executive order is any document comes from the White House that is labeled executive order. It's published in the Federal Register. It is used to manage the operation of the executive branch, may include directions on how to organize, regulate, spend funds. It does not create a new authority. Sorry, next slide, please. It does not create any new authority in the presidency, and it does not create any new authority for the agencies. And so essentially, although it is obvious, these are obviously important, you have to read them carefully. In and of themselves, they are generally just directions to agencies, how they're supposed to be complying or how they're supposed to be executing the agency actions. So briefly, let's talk about the executive orders that have been probably issued and are most relevant to the participants today. The first one is the executive order dealing with DEI, diversity, inclusion, equity, and this applies to probably everybody. This was written very broadly. It applies to anybody who's receiving federal funds, and also probably applies to private entities. The theory here being that DEI is in some way a violation of civil rights laws, such as the Civil Rights Act of 1964, because it is favoring one race or ethnicity or minority over another. And so the theory behind the executive order is that cases will be brought challenging those kinds of uses. The fact that the DEI requirements are actually on not only the entities themselves, but also on entities themselves when they're spending federal money, but are also in theory extended to any DEI done by those organizations. That is probably a violation of free speech, and there's at least one court that has enjoined the DEI application to in this context because of free speech. The OMB pause memo, we're all familiar with that is. That is probably, or a court found that was a violation of the Administrative Procedures Act, which I mentioned before, because it did not provide sufficient reasoning for why the pause was happening. The another important legal definition under an executive order is the legal definition of gender affirming policies. And the concern here is that the Anybody receiving federal funds could be subject to a to loss of their ability to engage in certain activities, and that would also be a violation of the APA. In this particular case, the legal definition of gender has been used to attempt to move a prisoner from a prison that was conforming to their chosen gender to a prison that conforms to their biological gender, and the court actually found that was a violation of the Eighth Amendment. The final order is prohibiting confirming support for minors for federally funded organizations. And the concern here is that this is limiting funding in a way that Congress did not intend it. Consequently, this probably has a separation of powers concerns. And the court has also found there are some equal protection concerns. So finally, let's just look at some legal resources. Sorry, next slide. So there are 70 executive orders. I would suggest that you go read the ones that are relevant to you. They're not that difficult to ascertain, but look at the primary document. And then there is a litigation tracker, which I have noted here, that breaks the cases up into the various under the different executive orders. And that would not only give you a sense of where the litigation stands, but it also might give you a sense of what attorneys would be people who would be able to help you if they're engaging in ongoing relevant litigation. So thank you so much, and back to Sadhana.
Thanks so much, Ken, and thanks for that kind of flash session on what's out there, what an EO is, what's out there, and also kind of some of the legal protections that do exist and are working as safeguards in this moment. Appreciate you running through that. We saw some questions, just some general questions that are coming through. We will be sending out the links afterwards. We will be sending out the slides afterwards. We will be sending out the recording afterwards. So just wanted to jump in with that. And I will turn it over next to Megan.
Great. Thank you, Sadhana, and thanks to the Health Begins team for inviting me to participate in this webinar today. And thanks for all of you for joining. It's really exciting to see the interest in this topic. And as someone who's worked in the health equity space for about 2 decades now, it's really nice to see some friends in the chat. Next slide, please. So I'm going to talk to you all today about the cost of cuts, Medicaid, health equity, and the future of care. I think folks know that cuts to Medicaid are currently on the table. So I'll walk through with you today about what the implications are of those cuts and kind of where things stand today. Next slide. Okay, being a little bit of a data nerd, I wanted to start with a poll if we can get that launched. I'm going to read the poll. So Medicaid provides healthcare coverage to what share of people in the US? 1 in 10, 1 in 5, or 1 in 7? We'll give folks maybe about 30 seconds to respond to the poll, and then we'll close.
I will say this is one of the fastest poll entries I've seen, Megan. So we have about 70% of folks participating already.
Wow.
So I'll go ahead and end the poll.
Great. All right, and we have a very smart group with us here today. Next slide, please. So nationally, 1 in 5 people are enrolled in Medicaid. 21% is the current percentage. But what we have to keep in mind is that this high-level statistic can mask the substantial state variation. So looking at the map on the right side of your screen, the states that are in the rose colored color here have the lowest percentage of individuals who are enrolled in Medicaid, and the ones that are in the darker blue, the highest. And the range that we see across the states is 11% of the population in Utah to 34% in New Mexico. Next slide, please. Okay, so while on the previous slides, I noted that 1 in 5 people in the US are enrolled in Medicaid. Medicaid plays a particularly important role in providing a source of healthcare coverage for certain populations in our country. And so I will try my best not to go through everything in this slide, but Medicaid finances over 40% of births, provides coverage to 4 in 10 children, 1 in 6 adults, 1 in 4 adults with disabilities. Medicaid covers 60% of nursing home residents and over 1 in 5 adults with a mental illness. Sometimes left out of the conversation is the important role that Medicaid plays for millions of rural Americans and American workers. We can see here that 14 million rural Americans are covered by Medicaid and 15 million American workers, as well as our veterans community as well. Next slide. So I like this slide. I've been using this slide for many, many years now, but Medicaid also plays an important role for communities of color. So on the left side of this slide, we see the distribution of Medicaid enrollees by race, ethnicity. So we look at the pie, all of the individuals who are enrolled in Medicaid, and we can see what this distribution looks like. 38% of Medicaid enrollees are white, for example, and 19% Black, 23% Hispanic. If we turn our attention to the right side, we see the percentage of the population that is enrolled in Medicaid. And then what's illuminated to us kind of through this comparison is that Medicaid covers a higher share of Black, Hispanic, and American Indian Alaska Native individuals relative to the white population, in which 30% of these populations, at least 30% of these populations, are covered by Medicaid. So again, Medicaid plays a very important role for communities of color in this country. Next slide. I want to take a little bit of time also to talk about Medicaid's role in addressing the social drivers of health or social determinants of health, as well as health-related social needs. So state Medicaid programs are increasingly using the authorities and options that are available to them under the program to address SDOH and HSRNs. Just to level set a bit, I'll use a definition from the Centers for Medicare and Medicaid Services. So CMS defines health-related social needs as an individual's unmet adverse social conditions that can include housing instability, homelessness, or nutrition insecurity that contribute to poor health and are the result of underlying social determinants of health. As an estimated, 80% of health outcomes stem from the social drivers of health, and these drivers disproportionately impact communities of color. It's been increasingly recognized that addressing socioeconomic needs is a critical key to advancing health equity. So I've listed here on the slide just a couple of resources from CMS where you can read more about their guidance and some of the flexibilities that are available to states. And then some examples of the way that states have leveraged Medicaid to address SDOH and HSRNs include, housing supports such as assistance finding and securing housing, mold remediation, for example, or home modifications like installing a grab bar to make it easier to get in and out of the shower, for example, nutrition supports like a meal delivery program, guidance around nutrition, healthy eating, educational services, and employment support. So really, my point of bringing these last few slides to you is that because of the important role that Medicaid plays in providing a source of coverage to certain populations, threats to Medicaid are inherently threats to health equity. Next slide. Okay, so, I think everyone is well aware that there are likely the House budget resolution calls for $880 billion in cuts, and what has been raised is the possibility of these cuts coming from Medicaid, the Medicaid program. And so this slide here outlines a couple of potential areas for Medicaid cuts, and also as well the CBO, the Congressional Budget Office estimates of their impact. I'll spend a bit of time with this, and I think there are some resources out there that will help you find more information about these where you have additional questions. So I think folks know that Medicaid is a joint federal-state program. Federal medical assistance percentages, or FMAPs, are used in determining the amount of federal matching funds to states for medical expenditures. The FMAP percentages take into consideration per capita income in a state and the amount of spend that qualified as matchable. So under current law, the FMAP cannot be less than 50%, and one potential option on the table is reducing this floor of 50%. Another option is that under the Affordable Care Act, states receive a 90% enhanced matching rate for adults covered through the Affordable Care Act expansion. It was 100%, and it was phased down over time to 90%. So that is something that's also on the table. Another option on the table is reducing states' ability to recoup federal funds through provider taxes. And another option is establishing per capita caps. I'm sure folks have heard a lot about this, but this would be a proposal that would limit the amount of federal funding for Medicaid programs by setting a fixed amount per enrollee. I think at the end of the day, I just want everyone to keep in mind that reduced federal funding in Medicaid means less money for states to deliver key services and improve care delivery. And without another mechanism to close the funding gap, there's a high likelihood that states would reduce services or limit eligibility. This obviously could significantly impact the overall health and well-being of people with Medicaid and negatively impact health outcomes and increasing costs. Next slide. And then this slide's just a quick snapshot of some of the impacts of potential Medicaid funding cuts. So Medicaid accounts for 20% of all healthcare expenditures, 8% of federal outlays, 30% of state budgets, 50% of federal fund transfer to states. And I think another thing to keep in mind as well is that, Medicaid is a key funder of long-term care services in this country, funder of disproportionate share hospitals, as well as local education agencies as well. Next slide. And this is the last one I have here today. So where do things stand today? I think an important thing is that the House vote on the budget resolution expected to take place this week, possibly even today. Because the implications of Medicaid cuts aren't split across, party lines, some GOP leaders have been pushing back on those cuts. I've listed a couple of data points here about Medicaid enrollment. So one example is that the percentage of Medicaid enrollees is generally higher in Medicaid expansion states, and this includes 21 states that voted for Trump. Politico did an analysis of Republicans in competitive seats, and they found that there are larger than average Medicaid populations in these areas as well. And then advocates and others have been taking action to protect Medicaid. And this is not an exhaustive list, but just wanted to provide a few examples of some of the actions that are being taken. So the National Health Law Project has Medicaid Defense. California Healthcare Foundation has a Defending Medicaid Medi-Cal in 2025 page that lists resources around the Medi-Cal program. And then Protect Our Care has a Hands Off Medicaid campaign as well. And I will stop there. Thank you so much, everyone.
Thanks so much, Megan. Appreciate that lay of the land that you provided for us. There were a number of kind of specific questions to your presentation in chat. Unfortunately, we don't have like the reply function enabled, but to the extent that you could kind of go in and answer some of those specific questions about your presentation via chat, that would be helpful. And we're still seeing questions about the webinar, links and recordings. We will be providing those afterwards. And so now that we've done some of that level setting and sense making about what is happening right now, I'm going to turn it over to Annie to take us through some strategies.
Great. Thanks, Adana, and thanks again to the Health Begins team and the wonderful folks I'm able to join this panel with. My name is Annie Ching, and I'm just going to quickly move to what folks are thinking right now. Can you go to the next slide? One more. There's a lot of change happening in our sector. I want to name for all the leaders on this call, this isn't the first time that our sector has faced uncertainty, has faced change, although the pace and depth of uncertainty right now is definitely unlike any that I've seen. And at NFF, we know that nonprofits have continued to be there for their communities throughout these changes that we've seen through the recession, through COVID. I'm based here in Pasadena, through the fires that have hit and other really environmental impacts that our communities have faced. So what we wanted to share today were some opportunities to really lead through the current uncertainty. And as leaders, you're dealing with the financial implications of what could happen right now, while also still advancing mission, taking care of your staff, and fostering the community resilience amongst the communities that you're serving. So as we breathe through what we think might be happening, we wanted to share some steps you can take that are really able for you to build some things that you can actually act on right now. Starting off with assessing where your organization is. What are the strengths that your organization has and that you can rely on right now? Both your community partners, your staff, the funders, the board that you know are going to stand by you through these times. What are those strengths that you're going to be relying on? And what are the risks to your organization as well? I'm going to go through some tips on scenario planning as you think about those risks. But what are the biggest risks that could potentially impact your organization? And what are some of the minor ones? And where do you feel it's most likely going to happen? And I know that's such an incredibly difficult thing to think about right now with so many unknowns. But what we want to do is be able to center on thinking through what happens if those things actually happen, so that you as leadership can make informed decisions with time to react. And we know that the hardest thing to do is to have to react immediately without thinking through what some of those actual implications could be. The second step is being open about your financial situation, keeping your funders informed about the impact of the current landscape and what it's going to mean for service delivery. We know there is a power dynamic with your funders, but everything we continue to hear from funders is that they would rather know about what the risks are earlier on. And that helps to inform what practices and what actions they can take to be able to support their grantees. Number three, coordinating and collaborating with your peers. This is both in working together for services and being able to serve the communities that you're working with, but also perhaps in being able to advocate together, because we know more voices together on the same message can have more power than single voices. Number three, staying the course on advancing health equity. This is the moment that communities need us to be there and to not roll back the progress that has been made over the last couple of years. And this is a time to be able to continue to speak up for the voices of those that you're serving, understanding what are the rights for your organization, but also what are the rights for those that you're serving. And I would highly encourage that there are many pro bono services right now that you can access to be able to make sure that you're within your rights and do any review of any language, any policies and programs that you have if you do think that there's any risks to them. Number five, there's an assumption that in the nonprofit sector, bigger is always better. And we really want to offer that this is the moment to really be investing in staying the same size. And there's a lot of value in continuing to be with your communities at the size that you're at. And that could mean being able to maintain the same size, yet still investing in your reserves, investing in your infrastructure, investing in your current staff so that they can be there for the long term. And at this moment, it's not always that bigger is better for nonprofits and the services that you do. And lastly, if you are able to reassure your staff that, think that about what you know, about if there is any security in what you're seeing, the financial picture for your organization. Staff are one of the most important assets in the services that you provide, and being able to help them with any fears that they may have as they're reading the news or they're thinking about what some of the implications are. That's a great way to be able to help support them in the long term. Can you go to the next slide? As we think about one of the ways to assess where your organization is, scenario planning is a tool that helps turn some of those risks into what will we actually do about them if they happen. And I just wanted to run the poll right now to see how many of you all have already conducted a scenario plan for your worst case scenario. Apologies, I can't tell if it's already up. There we go. So have you conducted a scenario plan for your worst case scenario right now? A is yes, no, or I don't know.
We still have a lot of answers coming in, Annie, and it's about 53% participation.
Okay, give it 10 more seconds.
Okay, now it's slowing down a bit, so I'm going to end the poll.
Great. So we're at about 20% having done that scenario plan and 47% that haven't. I will say that it is a really great resource to take some of the things that you may be thinking of top of mind, your worst fears, and actually understanding what are the hardest decisions you're going to have to make. Can you go to the next slide, Hassan? We have a tool and as a also a very short video that walks you through the tool that's going to be linked in the chat right now. It's a nonprofit budgeting scenario planning tool. It allows you to look at, in this tool, 2 risks. You can always add more columns if there's other risks you want to map out, but it really quantifies the what ifs of what could be the situation. What if our main contract is no longer going to be a source for us of revenue? It's a very difficult thing to think through. I am not making light of how hard that is. But at this moment, to be able to walk through it with leadership, walk through it with your board, and being able to understand what are the difficult decisions we may have to make at that point, and what could we do to maybe tell the story so that we don't have to make those decisions. Until you walk through those steps and go through that difficult exercise, it may be something that just happens to you and then you just have to make the decision quickly. So we'd really offer scenario planning as a way to think through early, very difficult situations. Can we go to the next slide? Another one that is a tool that folks are using a lot right now, given pauses in funding, is being able to do cash flow planning. We also have a, we're going to drop a link to the cash flow planning tool that we have. Again, another Excel document that has a video recording of how to walk through that. But a cash flow planning tool allows you to see at what points during the year will you have a cash shortfall. And for all of you as leaders, you know that cash is so important to be able to pay the bills to keep your doors open. And if there's a pause in any of your revenue streams that is going to cause you to have to not be able to pay bills, we want to know, how soon would that happen so that you can access other resources, go to your funders to get bridge funding, to go get earlier payments on some of your grants if you can, or your pledges, or to access a line of credit. The hardest time to access a line of credit is immediately when you need it. The best time to access a line of credit is when you can plan ahead and you can show a strong you can show that you understand at what point during the year you're going to have a cash shortfall. And those are some tools we wanted to offer to you all. If you can move to the last slide with them. I know this is such a challenging time, and these tools are just one way for you to plan ahead. Lastly, NFF really believes in advocating for the sector and telling the financial story, each of you individually to tell your financial story, but also as a sector. So we would love if everyone here could take our State of the Sector survey that's open. It's been open since late January. It's going to be closing March 7th. And this is the 10th time that we've done this survey. And we feel that it's more important than ever to be able to lift up to philanthropy, to your local public systems and our national systems. So really hope folks can take this survey. And thanks so much, Health Begins, for having us.
Thank you so much, Annie. This was wonderful. And, a lot of the tips and insights that you shared are really applicable beyond nonprofits as well. And we know we've got a varied audience here. So thank you for sharing that. And just a note on the background, I know a number of folks are messaging us directly just with your positivity and energy, and really appreciate that as well. So thank you for all of the kind of positive feedback on the resonance of all 3 presenters so far. And I will turn it to our final presenter, Josh.
Hi, thank you very much. Thank you for the opportunity to discuss how healthcare risk management, patient safety, and ethics kind of intersect in this kind of rapidly changing landscape. Next slide, please. No system, of course, whether it's the stock market or healthcare or even a single hospital, functions well under instability. And there are proven models for change management, and none of those which, of course, involve chainsaws. There is instability and shifting priorities that create an unpredictable policy environment with things like the changes in Medicaid, the reproductive health care laws, LGBTQ protections, public health funding. All of these create uncertainty. And meanwhile, we have a rising patient vulnerability that's rippling through healthcare systems, increasing financial, legal, and reputational risks for organizations. And this instability also fuels real-world risk events like violence against our healthcare providers, workforce burnout, and the erosion of all the DE&I and health equity efforts that have already been put into place. It also includes fear. There's fear of patients seeking care, fear of staff speaking up. So we look at enterprise risk management. It offers kind of a roadmap to navigate some of these challenges with kind of proactive, ethical, and equity-driven leadership. So by identifying risks, assessing their impact, and implementing mitigation strategies, we can help ensure that healthcare institutions don't just react to inconsistency, but they end up leading more with integrity. Next slide, please. As healthcare leaders, we have to navigate these unprecedented challenges with integrity, safeguarding both institutional viability and public trust. And true risk management goes beyond crisis and compliance. It's about the ethical responsibility to our patients, staff, and our community in order to ensure long-term resiliency to change. In an era where change threatens to overshadow compassion, healthcare leaders must step forward, and they need to not just react, but to lead. The question isn't whether we will face these challenges, but how we choose to navigate them. And one key strategy is aligning risk management with value-based advocacy, ensuring adaptability while upholding ethical commitments. Leadership in these times is really about protecting both the institution and the person. And while we do this, collaboration is crucial. No department can tackle these challenges alone. We must bring together health equity teams, risk management, patient safety, ethics, legal experts, and so forth, in order to anticipate unintended consequences, as well as create clear, proactive protocols to address them as the changes come forward. And we also have to really engage our frontline staff. These are the people that face the real world ethical dilemmas and can identify misalignments when policies and realities kind of intersect and connect. And not all risks, of course, can be managed inside a hospital or even with inside of clinics, right? Well, that's why partnering with local organizations is so critical to closing gaps where federal and state policies will fall short. So by collaborating with community groups, we can develop interventions that reduce systemic risks while maintaining ethical and moral integrity. And finally, data is a powerful tool to tell our story. By including demographic and social determinants of health data in safety event reporting and investigations and using real-time dashboards, we can identify risks related to inequities and intervene before actual harm occurs. Integrating risk, ethics, and health equity into every decision, whether it's policies or investigations, create resilient, responsible, and just healthcare systems. Next slide, please. Now, here are just some key questions that you can have in your back pocket as you begin to explore these challenges, or if you're looking at building a risk assessment model. Start with leadership. As healthcare leaders, we have to proactively integrate social determinants of health and political determinants of health within our enterprise risk management frameworks. This means emerging threats to patient care and institutional stability needs to be looked at before they actually escalate. We also need to talk about psychological safety and reporting inequities. If staff are afraid to report because of retaliation or dismissal, we risk silencing critical insights that could improve our care. Every policy or operational change has ripple effects, particularly on marginalized communities. So we are systematically hoping to assess unintended consequences before these policies get changed or made. And then finally, data has to kind of drive our decisions. Are we using analytics to detect disparities in healthcare outcomes before they become full-blown crisis? In addressing health inequities and operational risks, of course, is not a solo endeavor. It requires a lot of structured cross-functional teams. The key question for me is, how do we foster collaboration to proactively navigate policy and operational changes? Because too often, risk management is managed in silos. And instead, we have to create more formalized channels of communication to map out challenges before they actually reach the bedside. And this includes identifying legal and ethical risks early, aligning our policies with patient safety goals, and ensuring compliance efforts don't unintentionally create new barriers to care. And then the frontline workforce is essential to this process. Are we actively engaging our staff to understand real-world dilemmas and unintended consequences of our decisions? And then proactively supporting patients, especially where vulnerable or marginalized populations come in, has to be a core component of what we do. This starts with embedding social determinants of health screenings and stuff like that into routine care. But identification isn't enough. Are we ensuring patient safety initiatives explicitly address disparities and discrimination risks? And if we fail to do that, inequities are going to persist despite our best efforts. Another critical consideration is how we rebuild or build trust, because what strategies can we implement to reduce fear and increase engagement in this process? And how are we leveraging community partnerships to close those gaps by shifting policies? The most effective risk reduction strategies extend beyond hospital walls, and they really kind of help to meet patients where they are. Next slide, please. Here are some, there are very few meaningful risk assessments out there that exist around health equity. Traditional enterprise risk management frameworks really haven't adequately addressed social determinants of health or health equity risks, which is why making this a focus in your institution in collaborating with cross-functional teams is so important. And here are some resources for you to consider. The American Society for Healthcare Risk Management has created it's called the Equity of Care Assessment. And it's a great starting point to conduct equity risk assessments within your organization. It's a practical tool. It's more regulatory driven, but you can adapt it. And it's really designed to help organizations evaluate their risks. And the AHA and the AMA have done a lot of resourcing around this issue. So getting their insights is really important when you're starting to develop policies. So thank you very much for your time. I look forward to your questions, and I'll hand it back over.
Thanks so much, Josh. And a number of questions came in for you during your presentation as well. And we'll try to get to at least one. I know we're coming to the end of time here. I did want to kind of circle back with what we started with, and Josh really rounded us out nicely with some, real life tactics that we can use within healthcare settings to take the risks that we know about and make sure that our health equity work doesn't fail alongside kind of the risks that we're seeing. And I think if I could pick a moment, I loved when you said leadership means to protect both the institution and the person. And so what we are doing here at Health Begins, if you go to the next slide, is really inviting you to come on this journey with us. If you go to the next slide, you'll see kind of a prototype of something that we're embarking on to follow the same path that we took on this webinar. First, to help folks understand what's happening, to help them not just fall into the rut of reading headlines without feeling kind of power or impact statement. We're starting a Health Equity Policy Hub. And what you'll see on the screen are these cards that unfortunately use the name of the executive orders or the executive actions as they are titled, but quickly also translate what they are intended to mean. As you click on the card, if you go to the next slide, You'll see ways to get quick translations and anticipated impact in easy to read formats. And most importantly, and so to help your organization do that kind of assess, analyze piece that was in the middle there. So we want to understand, we want to assess and analyze, and then we want to convert to action. And so what we are intending to do is also then provide some tips for taking institutional action. We've had a number of conversations over the past few weeks, especially about how, it's helpful to have those institutional action kind of explainers to take back to folks for their decision-making teams and understand, what they can do in this moment to be able to protect the health equity efforts that they've invested in, that they are passionate about. And so this is just one vehicle for that. We also have had a number of conversations about how it needs to convert into in-person action as well. And so if you go to the next slide, a companion piece for the Health Equity Policy Hub is a mobilization network. And so we are actively recruiting volunteers to lead local pods. So while we'll be doing kind of this like inventory and understanding policy, understanding piece in the background and analysis, we also want folks to be able to lead local pods with like-minded individuals in your locations. We'll be able to support with tools and resources that you'll gain access to. If you go click once more, you can see some of the other benefits of participating in a mobilization network, and then have that support to convene local pods and commit to actions locally. And there's an interest form in the chat that Vassem just dropped. So if you do think you're energized by the idea of either the tracker, the mobilization network, all of it, with either your time or resources, please fill out the interest form and we'll be in touch with you as we build this out over the next couple of weeks. With that, we have barely any time for questions, but I do want to kind of pull up to a couple if possible. Megan, I might start with you, if you don't mind, on the questions, because we got kind of a pairing of questions about like the waivers that have previously been granted and whether those are safe. And also if you know anything about kind of the health-related social needs work and kind of how that intersects with race ethnicity issues right now. How is CMS kind of handling that from your best kind of vantage point?
Yeah, I can't answer the CMS question, unfortunately, and I'm not a waiver expert, but it's my understanding that we don't yet know how the new administration is going to treat certain waivers, that had previously been approved or even, promoted under the previous administration, including those focused on SDOH or health-related social needs. The administration could choose not to approve certain waivers that are pending, or take away certain guidance that had been promoted before. They could withdraw approved waivers as well. I think we don't know, but I think with budget cuts, in the context of budget cuts, states are at the end of the day going to be faced with really hard decisions about what to prioritize in their states, which are, invariably is going to result in the reduction or elimination of certain programs.
Thanks for that, Megan. And I think, as you mentioned in your presentation, now is a great time for folks that are concerned about that to get in touch with people in power and let them know that, they are concerned about those threats and what that may mean for their programs. There is another question, and Josh, I'm going to ask you this question about how can equity leaders call in risk assessment leaders to be able to engage in their decisions? Have you seen kind of how these teams are formed? You kind of offered some teams that should be forming, and if you have any tips on how to bring in risk management.
Of course, it's always a contingent on the culture in which you are in. So how the organization is structured. I always begin with trying to identify a leader, somebody in the senior leadership that is passionate about this topic, because there often will be one or two, and try to get them to help champion you so that you can know which buttons to push and which levers to pull in order to get things done. If worse comes to worse, start with your risk manager. Just contact your director of risk management and just say, hey, I'm really interested in this and how it impacts our exposure from a risk management perspective, and they will have probably some really good ideas about how this is going to work. Also, your compliance officers often will have some ideas about how to maybe structure or formalize this in a way that's not going to create problems downstream, but also is in alignment with the values and the operations of that organization.
Yeah, that makes sense. Have you seen kind of in other settings how those collaborations have come together, whether it's like natural disasters or public health emergencies, where kind of folks are working together in that space?
Yeah, like for example, when you're dealing with things like a natural disaster, right? We have created frameworks for that particular thing, where an organization will create some kind of a base of operations and knowledge and information, where all information kind of goes through that. And I think that is kind of a similar thing, because this is so specialized that a lot of information can go through one specific area, whether it's through a culture committee or some kind of through a leadership discussions, or a leader driving change. So there are opportunities for that. There are frameworks. Your internal emergency management plan is a really good example of how that kind of can work.
Thanks so much for that. Annie, I'm going to go to you for the next question, which is kind of about, we are seeing like CBO funding really impacted, right, in this moment. And so for these partnerships, kind of how can these collaborations continue? How can folks at institutions that might not have stop funding orders support others? Have you seen any real life stories about funding pauses or ways that kind of funding disruptions are being solved collaboratively?
Yes, definitely appreciate that there's some that have already experienced pauses in funding. To my point earlier about understanding what's the impact for your organization, these are stories to go to your funders with, and potentially to those that can provide bridge financing for you. Our hope is that these pauses will be found unconstitutional and that they will be able to be continued at some point in time. So is this really just a period of time where you need access to capital to bridge you through until that funding comes back and paid? Or is this really an end of a contract? Are you no longer receiving that revenue source anymore? And I think being able to tell that story to funders and being able to see if you can access a bridge loan or a line of credit, if you believe that is really a temporary fix, or if it's an emergency grant that you need in this moment to be able to keep services continuing, and being able to continue that until there's a decision made. I think that's one of the key tools that you have right now outside of making levers with your expenses.
Thanks so much, Annie. Can we have this question? I'm not sure that you can answer, but you can give it a try. It's really focused on kind of the definition of DEI within the EEOs. And I know you're a constitutional expert, maybe not on DEI definitions, but folks have questions around, how is it being defined? Is it really impacting health equity? I'll add just a color on it that we've seen anecdotally that organizations have been receiving stop orders, even though it's not what we would consider DEI, it is actually health equity. And so maybe the question is, if you know anything about how it's being defined, that's helpful, but more broadly also, when the definition is unclear, what does that mean for how it's being applied?
Yeah, that's an excellent question. The executive order does not define DEI. DEI really could be encompass many, many things. And I think, again, this goes to the issue of executive orders aren't actually the interpretation. Executive orders are really just directions to agencies to go ahead and implement some policy. And in this particular case, it just seems like the agencies also don't know what DEI is and consequently are not executing this in any really kind of careful, considered manner. I think I'd like to just say generally that the issue with a lot of what's going on here, it's not what is being done, it's how it's being done. Normally, something like this would be done with either regulations or policy directives or letters or in kind of a slow procedural way. Instead, it's being done very quickly, very haphazardly and perhaps inconsistently. So it really is the most possible challenging way to evaluate risk. And it is certainly the case that certainly lawyers are always pretty good at choosing the most cautious path, which might not be the most helpful path based on just risk. And it's very hard to assess the risk when we don't have the actual legal parameters. And so I do think just holding still long enough to figure out what's going on is one of the strategies. Not holding still in terms of stopping everything, but recognizing that there's going to be uncertainty and it might take a while to be resolved.
Thanks so much, Ken. I know we're coming to the close of time, but your comments really help shed light to some of the things I'm seeing in the chat, which I can't fully read while I'm facilitating here, but I do see concern about data and language being scrubbed, and how do we move forward when that is happening? This is a historic moment, and I really take to heart this part about, well, what is being asked, what is being ordered, and let's kind of create new ways of either accessing data, or determining like we are not able to keep data on people's immigration status. Like that's just going to be a future that we have to live in for right now, because it's just too risky. There are components of data that we know will be too risky. Other components that, to Ken's point, are being kind of scrubbed in advance. And so just really interrogate what we do need to be cautious about collecting, and create new mechanisms for preserving data as we can moving forward. So thank you all for your questions. If we can get the slides back up, I'll close this out here. I'm sorry we're over. Please complete the follow-up survey, including what you want to hear more of. Thank you all for joining and your great questions. A huge thank you to our knowledgeable presenters for jumping in a true rapid response fashion on this. So Ken, Megan, Annie, and Josh, thank you so much. Thank you to the Health Begins team who came together with your time, ideas, connections, and energy to make this happen. So Bassem, Bobby, Glasha, Bailey, Ellen, and Rishi. As we mentioned earlier, we'll be sending out this recording to all registrants along with the slides and the links that were in chat. At the end, you'll see a survey pop up. Please fill that out. Let us know what you want more of. That interest form, let us know if you want to help begin this health equity policy hub endeavor that we're starting out on. This is an ongoing conversation. Tag us at Health Begins on Blue Sky, and we hope we'll see you at our next webinar, which is Tuesday, March 4th, so a week away. Our comms team has been working hard, and we hope you register and join us there. Thank you all for your energy and your insights.